Okay, Assalamualaikum warahmatullahi wabarakatuh and very good morning Malaysia Madani. The reason why I cannot talk just now because the speaker, the mic, not the mic, the camera, because we're having a virtual participants. Welcome to the second day of WISAC, Wilayah Persekutuan and Selangor Anaesthesia Conference 2023 organized by Hospital Ampang. Congratulations to them. So my name is Azizan. I would like to welcome the physical participants and also the virtual. Hello. You might actually see me in MSA, the unofficial ambassador. There are many, I look through at the attendance lists. There are many pakar-pakar. So please join MSA and also college. And also for the pakar, there's also obstetric anesthesia fraternity, Persatuan Obstetric Anesthesia Malaysia. You can join that as well if you want. Okay, so without further ado, because we are running tight on the time, so it's my honor to moderate the obstetric anesthesia tract symposium for today. We got two distinguished speakers. Both are still my teachers. Let me introduce first my first speaker. Okay, I don't think he needs, he might be a bit low profile, but I'm sure most of you know him. To cut the story short, he'll be the next Malaysian anesthesia boss very soon, next month on the 6th of December 2023. Okay, he also has, let me tell you about CV dia. I'm not going to tell about CV, but his hobbies, outdoor activities, mountain climbing, diving, all that. That's why he looks so young. But he's married. But I think the other speaker pun younger looking actually. And me, because I had a late night sleep last night, so tak nampak sangat lah. Oh, adik Luffy pada. Hello. So I think that's why I joined the obstetric anesthesia fraternity, because then you look young. Don't know why, maybe because playing with placenta or giving epidural or actually skin touch with the newly born infant. Okay, without further ado, with the topic on persistent pain after lower segment caesarean section, please put our hands together and say congratulations on the promotion to A recently. I would like to invite my boss, Dr. Rohisham Zainal Abidin.
Assalamualaikum warahmatullahi wabarakatuh and very good morning everyone. First and foremost, I must thank the organizing committee for inviting me, and I must congratulate Dr. Sani, Hospital Ampang, Dr. Rosna, and Dr. Hairul, and of course Dr. Amir and I believe there are a number of others who actually make this conference success. I know it's not very easy to organize any conference, even a small, so-called small conference such as this one. So my topic is persistent pain following caesarean delivery. I've got a little disclaimer to make. Dr. Liao Kylie is my medical officer. She's currently in HKL doing some rotation, I think, vascular. And Dr. Fauzi is my specialist in HTA, so they actually did me with the slides. Okay, so as an introduction, persistent pain after surgery affects 10 to 50% of patients after various surgical procedures, be it herniorrhaphy, breast surgery, thoracic surgery, leg amputation, and even coronary artery bypass surgery. Women are actually at higher risk of developing persistent pain following surgery. LSES, I'm sure in our country, is actually one of the commonest surgery performed in our country, and of course in the US also. So in the US, it counts to about 31.9% in 2016. But in our country, the number is actually also about the same, probably a little lower than the US. But I can attest to you that I don't have the exact statistics, but our caesarean delivery accounts to about 30% of total surgery in our country. So making, again, LSES the commonest surgery performed in Malaysia as well. So the increase in LSES performed over the years makes a significant burden, both financially and quality of life, for a large number of otherwise healthy women. So I'm sure, over the years, we are actually seeing more and more cesarean delivery being performed, you know. I'm sure when you are doing your elective cesarean section, tu punya dalam your list ada patients with 2 previous section coming in for repeat surgery. It's just increasing year by year. So this persistent pain has been shown to be associated with postpartum depression and it interferes with daily activities and sleep disturbances. Hence, the newborn is also affected by the pain. Severity and duration of post-operative pain and its management may be predictive of developing persistent pain at 2 to 12 months later, meaning to say that how you manage the acute pain post-operatively is very, very important to prevent persistent pain later on. Incidence of persistent pain after LSES is considered accounted to up to 23% at 12 months post-surgery. It is noted that this incidence of persistent pain following LSES are actually lower than hysterectomy and inguinal herniorrhaphy. Some authors stated that probably is the effect of the hormonal state of pregnancy mediated through oxytocin that conveys some protection. But I think there's another slide that I will add a bit further on why patients with hysterectomy and inguinal herniorrhaphy actually has more pain than cesarean section, post-cesarean section. You all should know this definition by heart. Persistent pain is clinical discomfort lasting more than 2 months. So post-surgery after exclusion of other causes such as post-operative chronic infection or pre-existing chronic pain conditions. So this is the definition by the International Association for the Study of Pain. Yeah. So what's the characteristic of persistent pain following cesarean section? So Niklasen et al. Studied 260 healthy women who underwent LSES. 46% had pain at surgical site at 3 months. 32% at more than one location at 3 months. 25% pain at more than one location at 6 months. Abdomen more commonly reported at 3 and 6 months. Back pain more common at 12 months. And more than 20% with moderate to severe pain describe the pain to be as impacting their enjoyment of life. So it's actually a significant problem. So what about in our own backyard? Yeah? Is this really happening in our own patients? Actually, many of us are actually after our giving anesthesia to our cesarean section patients, we never care about what happens afterwards, isn't it? So normally we just see the patient maybe 1 or 2 days post LSES, but we never do follow up whether they do develop chronic pain or not. So we actually conducted a small survey just by using the Google form. So thanks to Dr. Siu, one of my specialists in the department, just to find out the prevalence of patients who had complaint of chronic pain post-cesarean delivery. Location of pain, where the patient was being reviewed, the management of pain and breastfeeding status were asked. We didn't actually call and ask the patients, but because it was a bit too difficult to do within a short period of time, we actually sent this Google sheet to a number of doctors, a total of 61 doctors from the discipline of ONG and family medicine. 65% of doctors that we sent the Google form actually reported encountering patients with chronic pain following cesarean section. And 40% of those 60% of the doctors actually encountered at least one patient with chronic pain following cesarean section. 20% had encountered more than 5 such patients in 1 year alone. So where does the patient complain of pain? 65% had pain at the operative site. 65% also had pain at lumbar or back, at the back. About 11% at the pelvic area, and none had pain at the vaginal area. Where were the patients seen? Most of them was actually seen at the private clinic or in our clinic kesihatan lah. So basically, it's not within the in the hospital. So that accounts to 65%. 30% were seen at tertiary hospital, and another 4.6% seen at the district hospital. Majority of them got their treatment from the clinic kesihatan or the private facility, GP. 58%, only 18% managed by pain specialists. And interestingly, though that 40% actually self-manage their pain. So you need to know that persistent pain in our country do exist, and it's highly possible that they are mostly overlooked and definitely undertreated. So we must acknowledge its presence in our own patients and do the necessary to reduce the occurrence. So yeah, bear with me. This pathophysiology of persistent pain after surgery, I think is important. It represents a failure of hyperalgesic state during surgery. Yeah. To return to pre-injury or pre-surgical state despite completion of tissue healing. So you may be recovering from the operation itself, your tissues may be recovered, but the hyperalgesic state may still remain. So it's because of combination of both inflammatory response and also nerve injury. So nociceptive pain is due to stimulation of nociceptors from actual or threatened nerve damage to non-neural tissue during caesarean delivery. Release of inflammatory mediators at the site of direct tissue trauma resulted in increase in local sensitization of pain by decreasing firing threshold of nociceptors. Surgical procedures damages nerves in the body leading to neuropathic pain. Phalansteal incision has risk of ilioinguinal and iliohypogastric nerve entrapment leading to pain at the scar. Any obstetrician here? I don't think so, yeah. So do you know what's the common incision that they make now? Phalansteal? Are they still doing phalansteal incision? Do you all know? Masih ke phalansteal? Okay, now we'll see afterwards. Pathophysiology unique to persistent pain after caesarean delivery. Incidence of persistent pain is 10 times lower than similar invasive surgery such as total abdominal hysterectomy or inguinal herniorrhaphy. So despite that, it's actually still lower than patients who had hysterectomy or herniorrhaphy. Yeah? So why? Because it's most of the time the scissors should be shorter than the hysterectomy. Less peripheral nerve injury, positive psychological factor. It's actually how to put it? Supposed to be a happy occasion for the couple and for the mom of course expecting a newborn. And the pregnant state, and as mentioned earlier, that the possibility of the hormonal influence of oxytocin released in large amount during parturition or lactation. That's why making cesarean section, pain following cesarean actually less compared to hysterectomy and herniorrhaphy. Preoperative factors, risk factors that can actually tell us whether this patient can later on develop chronic pain or persistent pain includes psychosocial issues like anxiety, depression, lower socioeconomic status. Patients who had their first LSCS are at higher risk. Opioid-induced hyperalgesia, pre-operative opioid use, previous opioid exposure or repeated exposure. These are patients who already had issues with, maybe have some pain in their body and they are on some opioids. So they are actually at higher risk of developing persistent pain as well. Maternal request for caesarean delivery. So this is also another risk factor for persistent pain following delivery. So actually, I don't like this indication when obstetrician now like to write maternal request. Sebenarnya, I don't quite like it lah. Normally I ask my MO to ask the patient why do they actually the obstetrician counsel them for caesarean delivery. Normally there is some reason lah. Of course, there's a good reason, be it infertility or subfertility, precious baby, or large for gestational age, CPD or whatever. I think that should be the indication rather than putting in as a maternal request. I think when I was in training, I never come across this indication, Prof. Low maternal weight gain is another risk factor. Pre-existing pain and pain as well, I've mentioned before. Okay, patients with repeated LSS has higher percentage of chronic pelvic pain. It's a risk factor for persistent pain after hysterectomy as well. Increasing prevalence of patients with multiple LSCS, I've mentioned, may put this patient population at higher risk of persistent pain after any surgery. So not only cesarean, following cesarean delivery, but if they need to go for, let's say, cholecystectomy or hysterectomy, they're actually at even higher risk of developing persistent pain. So this population of women should be treated aggressively during the acute pain or acute post-op pain period. So intraoperatively, so this is also important. Patients who has emergency LSCS, bear in mind in our country, 60% of cesarean section are actually emergency. GA has got a higher risk of developing persistent pain compared to RA, twice as more likely. A patient who was given intrathecal morphine, I think now everybody use intrathecal morphine everywhere, has actually less risk of developing post-op pain, persistent pain. Lower dose of spinal anesthetic, of course, if you use lower dose, higher risk of you getting the pain, acute pain earlier in the recovery period and pose a risk of persistent pain. Okay, this is about the phalansteal, coming back to the phalansteal incision. Actually, from my short survey in my HTA obstetric department, I did go around and ask a few of the medical officers. Actually, they have been performing Joel Cohen kind of incision instead of phalansteal for actually quite a long time. It's just that we were not aware. Joel Cohen ni dekat mana? Kalau phalansteal, everyone knows, isn't it? Siapa tahu Joel Cohen incision dekat mana? Nobody, I pun baru belajar sebenarnya. So apparently Joel Cohen is actually a shorter incision. So it also allow for faster delivery, therefore reducing operative time, less post-op pain, and associated with less post-op infection, and of course shorter hospital stay. So it's actually been proven. Whereas the time-tested phalansteal incision found to have increased risk of nerve entrapment, basically the inguinal iliohypogastric nerve. Formation of neuromas even at the site of incision, which contributes to increased risk of neuropathic pain and therefore persistent pain following cesarean delivery. So this is where Joel Cohen incision is. So that's your phalansteal. Probably those days when they started doing phalansteal, basically because of cosmetic reason, they say they want to hide the bikini line or whatever. So, but of course, this Joel Cohen, you need to wear a bigger bikini lah, maybe a extra size. Right. So what about post-operative factors? Postpartum depression definitely will cause increases of persistent pain and severity of acute post-operative pain, meaning immediately after surgery, in the recovery, or 1 or 2 days after surgery. This is where it's important to actually identify and treat this acute pain patients effectively, so that we can try to reduce the risk of developing persistent pain later on. Patients who had complications following their cesarean delivery, for example, wound infection, endometritis, and those who had PPH, excessive bleeding, also had risk of persistent pain following cesarean section. Okay, can we predict which patient that can develop acute and persistent pain? Also, there are actually, in theory, quantitative sensory testing such as heat pain threshold, extensive psychosocial questionnaire using this Spielberg state trait anxiety inventory. I actually didn't bother to go and read further because I think it's also time consuming to read and actually time consuming to perform as well. So it's not practical in our setup. But I think we can probably adopt these 3-item pre-operative screening questions developed by Pan, PH et al. So you just need to ask about 3 questions to the mother, or assess 3 things, which is number 1 is maternal anxiety, and number 2 is anticipated post-cesarean pain, meaning how does the mother anticipate pain following a cesarean delivery, and whether how much of anesthesia need that they anticipate following surgery. So these are the simple 3 things that we can ask, which has been found to correlate moderately with evoked pain intensity 24 hours after cesarean delivery. So probably you can adopt this in our practice. Okay, another interesting fact is actually red heads lah, or do you know who this is? Siapa tu? Azizan tahu lah. Siapa Azizan? Who? Actually, I don't know, but I know her real name lah. Nama dia apa? Actually, I forgot lah, sorry. Siapa nama? Oh, Scarlett Johansson, ya. Saja buat lupa. Okay, it has been shown that people with these genes, MCIR or melanocortin 1 receptor gene, responsible for hair, skin, and red hair. Lah. So this gene mediates greater female-specific kappa opioid agonist, example pentazocine. Yeah? So they have actually has got better analgesic, inherent analgesic properties if they've given opioids. So they actually tolerate pain better lah. Another one is cytochrome 2D6 or CYP2D6, which in this phenotype actually interferes with codeine, tramadol, oxycodone metabolism. So there are two groups. One called the poor metabolizers, which they cannot metabolize. Possibility resulting in reduced analgesia or requiring more other modalities such as opioids for the pain relief. Whereas the ultra-rapid metabolites generally have increased concentration of active metabolites, increasing their risk of opioid side effects or complications such as nausea, vomiting, respiratory depression, and so forth. So, of course, those genetic things are we actually, again, not practical, but actually good to know that, I'm sure you have encountered your patients, in post-op period even for other surgery. Sometimes you've given, so much of opioids, but they're still not responding. So jangan marah dia lah. Maybe they have that cytochrome 2D6 genes. So you need to bear that in mind. So prediction of acute and persistent pain. Other things include tissue and nerve injuries are main initiating causes of persistent pain. Modifying surgical technique can reduce tissue injury, inflammation or adhesion response. So surgeons need to reduce or avoid nerve injury and treatment to prevent or reduce risk of persistent pain. So I've mentioned about the Johor cone incision. So surgeons need to be careful and gentle during the resection. There are surgeons are very gentle. Sometimes you tak rasa patient tu gerak pun masa ni. Some surgeons macam patient tu nak jatuh katil pun ada. Dia punya retraction and today people are still exteriorizing the uterus. Masih dia orang keluarkan uterus and try to close the uterus. But in some skillful surgeon, they actually don't have to exteriorize the uterus. So that actually helps to reduce pain, acute pain. Muscle sparing technique, peritoneal non-closure. So actually most of the surgeons now don't close the peritoneum most of the time. Because it has been shown to actually again reduce post-operative pain. And some of you may ask whether this will increase adhesion or the peritoneum getting stuck to the bowels. Actually, studies have shown that actually there's no difference whether you close the peritoneum or not with regards to increased risk of adhesion later on. So it has been becoming a popular practice nowadays that they don't close the peritoneum. Of course, if you shorten the surgery, you will also cause less risk of acute post-op pain, and therefore we hope that it will also reduce persistent pain. Of course, another thing is multimodal analgesic regimens. This is what we've been doing already. So those of you who have not started doing this, please do so. I think you need to manage the acute post-op period following cesarean delivery more actively rather than just after giving spinal anesthesia and leave it to the obstetrician, which will normally they will only give IM pethidine or something like that, or Ponston those days. Yeah. So I think we need to be more active, proactive in managing the post-op pain following cesarean delivery. Most of our hospitals now use this protocol of Neuraxial opioids, then paracetamol, NSAIDs, and dexamethasone. Dexa, of course, intraoperatively, paracetamol immediately after delivery, and then NSAIDs started immediately after delivery, after surgery, and continued maybe 2 or 3 days after the operation. On the contrary, use of opioids for severe acute post-operative pain will increase risk of persistent pain. Basically, if the patient has got more pain in the perioperative period, you tend to use more opioids, and so they are actually at risk of persistent pain. And I think it was a problem in the US a few years back where physician routinely prescribe opioids, significantly exceeding patients' need, therefore causing the so-called opioid epidemic. This has never been an issue in our country. I think we do use our opioids, but we use it sparingly. NSAIDs and acetaminophen, both will reduce opioids consumption by 30 to 50%. I think most of us actually use diclofenac per rectal and followed by diclofenac tablet 2 or 3 days following that. You can also use the COX-2 inhibitors if you want, but of course, cost is a concern. TAP block, transversus abdominis plain block, or continuous infiltration of LA and NSAIDs at wound site with indwelling catheters for patients who can't have neuraxial analgesia. Basically, these are patients who probably has got OSA, morbidly obese patient, or patient who had to be given general anesthesia. So you may want to consider giving a TAP block or continuous infiltration of LA. And this has been shown to decrease pain score and opioids usage first 24 hours, but has not proven to be beneficial in decreasing chronic pain. This is also one interesting findings. If you've got a patient that you need to give a GA, maybe you can start considering giving IV lidocaine 1.5 milligrams per kilogram at induction, because most of us are still avoiding giving opioids prior to baby being delivered. And nowadays, the use of nitrous oxide being, side-eyed, you're not considering the effect of nitrous oxide on the environment. So most of us have stopped using nitrous oxide for many, many years. But some actually still have to give Enternox before the baby comes out, because we've got no other means of providing analgesia. So perhaps you can consider giving IV lidocaine. So studies are actually quite promising. Other drugs including ketamine, clonidine, dex, gabapentin, and pregabalin has all been studied, but again, I think we need more evidence before we can start using it routinely for cesarean, GA cesarean section. Okay, just to sum up, due to high prevalence of LSCS and low incidence of persistent pain actually affects large number of women. Women with previous LSCS are at significant risk, so you need to optimize multimodal analgesia and reducing nociception and acute pain by modifying surgical technique, jaw head coil incision, don't externalize the uterus, shorten the surgical duration, choosing neuraxial analgesia for LSCS. If GA is needed, supplement with regional blocks, maybe TAP blocks or continuous infusion local anesthetic, opioid sparing analgesic regimen, paracetamol, NSAIDs, and DEXA. This is my main reference. If you want to get further reading from that, so just a few more slides, Dr. Lee, just to advertise my hospital. So I'm sure many of you have not been to HTA. This is actually the complex rawatan ibu dan bayi lah, the one and only in Selangor State. Has got 18 delivery suites and 2 operation theatre lah. Up and coming is our new ICU floor. This is located in the 3rd floor. Actually, it's 24 additional ICU beds. Currently, we have 38 beds. 38 plus 24, never mind, don't do the mathematics. I'll do the mathematics for you. 38 plus 24, but we're going to minus 10. Once we open this 24, we're going to close we're going to close 16 beds. At the end of the day, we're going to have 46 ICU beds in total. We will be equivalent to, you tahu tak siapa yang sekarang ni ada ICU paling banyak di Malaysia? Bukan Sungai Buloh, salah. Sarawak? No. Melaka 46. Ada orang Melaka Melaka? Sekarang 46. Sebenarnya boleh jadi 50, but tak ada staff kan. So keep it at 46 because in January we want to equal your record lah. So we will also have 46 beds. So ini tak termasuk yang CCU, Euro ICU, Neuro ICU dekat HKL tu tak kira lah. So this is how it looks like. So hopefully it will be handed over to us end of this month, and we plan to open for patients to be admitted in January 2024. So It's got nice natural lights coming in. This is actually one bed, one cubicle for one patient, and so of course we need to put more things inside there. Another exciting thing is happening. HTA is actually not a popular hospital. Orang semua tak nak datang ke HTA. Normally, houseman ke yang datang report, I always ask them lah, why you choose HTA? They never choose HTA because HTA is the only hospital available dekat dia punya placement tu lah, selalunya lah. So, pakar pun sama lah. Normally tak ada yang nak datang ke Kelang lah. So dia suka pergi Shah Alam, Putrajaya, Cyberjaya, hospital yang kecil-kecil. But I'm sure all of you here yang hadir ni semuanya dedicated lah to become a specialist in the future lah. Takkan nak kerja ke hospital kecil-kecil, you kena target pergi HKL, Kelang kan. Janganlah pergi Melaka kan. So basically there's another exciting things happening. Ini LRT station lah, LRT 3, supposed to be completed in March 2025. This is actually very near to our hospital. Actually within walking distance. So that's the emergency department and that's the main block. This is actually an advertisement. So next year I'll be speaking again at the East Coast Anaesthesia Intensive Care Conference in Kota Baru in February. The title will be Anesthesia for Fetal Surgery. This is actually a real photograph I took from a hospital in Belgium. Okay, dia tahu tengah buat operation apa tu? That's actually the uterus, and they're actually repairing the myelomeningocele in the fetus, in the baby, at 24 weeks macam tu. Once after following that, they will close and allow the mother to actually go on to term and deliver by caesarean section later on. So hopefully I can see some of you in Kota Baru. Thank you very much.